everyone. Today we are very happy to have Dr. Danielle Mowery from the University of Pennsylvania School of Medicine come here to give a presentation. I have known Danielle for a long time since she's a student in the PhD in the Utah, right?
Uh,
Graduate because we both worked in the clinical NLP field and she has worked actually now I think go beyond just clinical NLP because she's the chief research informatics officer at the UPenn Medicine, and she's overseeing a lot of clinical informatics project at UPenn, serving on different committees as a co-chair for the UPenn Medicine Health AI Governance Committee, co-chair of the Association of American Medical College group on the information resources, also a member of the EPIC Cosmos Governance Council. And also a specific congratulations to Daniel for the elect to the Acme Fellow this year, right? It's just announced a couple of days ago. Really happy for you. Yeah. So without further delay, I'll just let Daniel to start the talk.
Thank you. Thank you so much, Dr. Chu. And thank you for allowing me to come here to present some of the work that's happening with my research lab. Really honored to be able to come here and to talk about what the cool stuff we've been working on the last couple of years. For today's talk, I hope to take you on an adventure from the bench to the bedside and beyond, and demonstrating how our team is building innovative solutions that can power insights in these different places. But as Dr. Shu had said, I do have a few disclosures to quickly make. Specifically, again, as he had stated, I'm a member of the Epic Cosmos Governing Council, actually with your CREO, Dr. Daniella Mowery, where we work with other informatics leadership throughout the country to help in giving input on design and functionality and guidance on reviewing studies and ensuring that they adhere to the rules of the road. In addition to that, I do serve as a member of the steering committee for the Association for American Medical Colleges, and want to also disclose that although I have not personally received salary support, my research core members, staffs have from Roche. But with that, I have to say, yeah, I've known Dr. Shu for quite a long time and have had a really fun and interesting journey over the way. I am a Pittsburgh native, so I did my training at the University of Pittsburgh, all 4 degrees, including a background in biological sciences, where I got to study, benchside, the central dogma of genetics, and moved to the clinical side by learning how electronic health records work, specifically with a master's degree in health information systems, then building on that, what kind of analytical capabilities we could do by bridging both these two different types of data together for learning how to provide better care and to optimize patient health. I did this while I was fortunate enough to get a 4-year fellowship through the National Library of Medicine to fund that training. And I'm also proud to say that I'm a first-generation PhD with my family. You can see here a really nice pictures of the University of Pittsburgh, including the cathedral learning, as well as a nice nostalgic photo of myself with my identical twin sister on our graduation. But during that time, I was also afforded the opportunity to do a student appointment visiting at the University of California, San Diego, actually under the direction of your department chair, Dr. Lucila Uno Machado, where I got to learn about patient privacy and different kinds of approaches to ensure that. Additionally, I got to spend a little bit of time learning about machine translation, so designing NLP systems that can port from English to other languages, and did a brief student appointment at Stockholm University. And then, as my postdoc, I went to the University of Utah, where I could learn more about how to do more applied clinical informatics and learning about data standards. And in that time, I got to take on some new leadership roles, first serving as the director of their NLP service line, providing NLP services to the health system and to the university. I also got to serve various staff roles within the Department of Veteran Affairs, where I got to conduct some large retrospective observational studies using big data. And then that kind of prepared me for my last role, which is just here at the University of Pennsylvania. And as Dr. Shu had mentioned, I am an assistant professor of informatics here in the Department of Biostats, Epidemiology, and Informatics. I serve as the CREO, where I develop people, platforms, and processes to support clinical and translational research. And when I'm not doing that, I oversee this clinical research informatics core that provisions EHR data for said studies. I also have a few large center grants, including serving as the methods core director for our suicide prevention implementation research center, as well as our sleep apnea center, which I realize I've missed. And I've been really fortunate to be able to receive recognition for some of our work through fellowship through FAMIA as well as ACME. So thank you so much for highlighting that. I'm quite excited about joining Juan and many others and at that table in the spring. So with that, this talk again is about how AI is powering innovations in these different spaces, the bench, the bedside to beyond. And for those who work in this space, like many of you, this is old news. We've been doing this for many decades, but for some, maybe on the more clinical side, this might be new to you. But it seems like AI is here. It's here, it's there, it's everywhere, meaning that it is, you can find it in most anything anymore. It's been democratized through works like OpenAI. You can use it to do more intelligent search on Google. You can see it in your home through digital assistants like Alexa. And it seems like the news has its own tabs and information tabs on artificial intelligence with the latest and greatest enhancements and tools that are available. With national interest growing in AI, it's also come to federal and organizational efforts to define and make recommendations about how AI is developed and deployed. And we're seeing more of an active role in that, starting with the Biden administration defining AI as systems that change the speed of innovation, particularly automated systems with the impact on American public rights, including opportunities and access to services. So that feels very broad. But we can look to a more clinical impact when we look to the FDA, where they're taking a more focused interest in the development and deployment of medical devices, referring to AI as software algorithms, focused on particular tasks of analysis, interpretation, comprehension of medical and health data. But we can look even a little further to the National Academy of Medicine if we want to think about the application of AI specifically for a variety of different types of projects, including, but not limited to, medical research, design of new therapies, diagnosing illnesses, as well as creating personalized treatment plans and more. With the right data, we know that AI has the ability to transform and innovate medicine from the bench to the bedside and beyond. And in the case of more basic science research, AI can help us analyze and discover patterns that can help us understand how lifestyle, genetics, and environment can help predict disease. At the bedside, AI can help healthcare professionals in keeping up to date on the most evidence-based practices from the literature to make better clinical decisions and to improve operational efficiency through streamlining electronic data capture and clinical documentation. We see this in use cases like DAX Copilot, for example, more recently. And for patients, AI can help them better understand their own clinical charts and how to manage their chronic disease at home. So for today, I want to introduce you to a few different use cases in which my research lab and my service corps have been working to apply AI to solve a variety of different types of problems. Additionally, I want to highlight the fact that we're kind of just starting to learn about how to use generative AI at the time of some of these use cases. And so some of these stories, I'm going to talk about how we kind of evolved and got our footing in this new and evolving space. But before I begin, we're gonna start with the bench, where I'm gonna highlight one use case where we're doing patient phenotyping, and then we're gonna peruse over to the bedside, where we're gonna have a few different use cases that vary from clinical operations like ambient assistance and clinical decision support like safety planning raters, as well as more quality improvement efforts like automating safety nets. And then we're going to end at the bedside, where we're going to circle back to the idea of being able to help patients manage themselves at home through digital chatbots. So we'll start with patient phenotyping. I will say, like at the beginning of the democratization of OpenAI and access of generative models to the masses, and particularly the largest ones, we were posed with this question of a use case where we wanted to use prompt engineering and use the largest language models to determine whether or not a patient had in-house cardiac arrest. And this is for not just quality improvement purposes, but also for some research purposes. And so, we were just getting started, like others, thinking, how do we go about this? How do we get the machine to do the things that we wanted to do? And we started by, like many, creating these instruction prompts to give the machine some context to, what the task is. So, for example, given patient note summaries, can we assess whether or not a patient had an in-house cardiac arrest event? And we were giving it, testing out some of the different ways and language that we could give it to understand what an in-house cardiac arrest is. Specifically, that a cardiac arrest occurs in the inpatient setting, and that's where the patient is receiving that care. And we wanted to, for our own purposes, to distinguish inpatient from outpatient, because in our definition, we only wanted to include those that had happened into the inpatient. So things that, if a cardiac arrest event happened in the cafeteria or during a visit, we wouldn't count it. So we needed to be clear about what to include and what not to include. We also need to give some clinical information about what it is. So here it refers to a sudden loss of cardiac function, leading to a lack of pulse or signs requiring that the patient receives chest compressions. And specifically, we wanted to give it some criterion to defining exactly what is necessary and sufficient to be able to classify a patient. And so, one, we needed to have a mention of cardiac arrest had happened. Two, we wanted to determine if the cardiac arrest occurred in the inpatient, which we said. And then three, the chest compression. So here, all three things need to be true in order to flag the patient as being positive with that. And so at the time, we worked very closely with our emergency department physician to define the relevant note types that were necessary for doing the phenotyping, specifically looking at discharge summaries, progress notes, plan of care notes, and assessments, and treated this as a prediction problem. For given a patient's case and the notes that are associated with it, tell me whether or not the patient had the in-house cardiac arrest, yes or no. And so with that, we thought, well, let's see if the large language model can use this information to readily determine whether or not the patient had an in-house cardiac arrest. But we were, when we got started, we were just coming out of the BERTs and the ELMOs and the other transformer phase, and we were getting into this really large language model space and asking ourselves, well, which one should we use? And so what lent itself very nicely about this problem is because it was quite simple, we could test a variety of different types of large language models. And so at the time, we had stood up a protected research environment called Microsoft Azure Databricks, for which we had a secure tenant of GPT-4 or 4.0, and meaning that it doesn't call out to the internet. It's our own local instance that doesn't learn from your data. And we had also the ability to load open weight large language models in through our local endpoints. And so we thought, let's look at those that are available. We selected about 36 general purpose large language models, as well as 15 medical, and we wanted to compare those against GPT-4o. And we did that for, again, a few reasons. One, we weren't sure which ones were going to be better. Do you need medical knowledge over LLM that might be general purpose? How good are these other models, the open weight models, to GPT-4o? GPT-4o was doing pretty good, but the cost associated with computing and processing the tokens might mean that, if we could do it cheaper with an open weight model, it might be worth doing. And so what you're seeing here is a results slide generated by my postdoc, Dr. Erjan Verkin, where again, he down the leftmost side here of the first figure on the top, you can see all of the different models that we tested. In red are the ones that are medical models. The one in gray are other models, and the most top performing are at the very bottom. So we're ordering them in terms of performance, descending order from F1 score. And a few things I want you to note is, one, we have a mix of gray and red all through that figure, meaning that there's not if we thought the medical models were necessary and most efficient, then we would expect them to be at the very bottom. But what we see is that there's a lot of variability in terms of those that perform best using a bootstrapping method to get the performance over. And another thing I want you to note here is that the confidence intervals on the mark. So sometimes you can see those are very wide, In fact, you could park a car between some of those confidence intervals are quite wide versus others that are much more tight, meaning that the estimate, the reliability of that mark when you ask it whether or not a patient had in-house cardiac arrest is going to be more consistent in its ability to answer that question. And so that helped us really quickly decide which ones to keep in and which ones to throw out and which ones to move forward with. Okay. Additionally, we were thinking, it's not just how well does it answer that question, but sometimes what we found was because they're generative, we'd ask it for a positive or negative outcome, but sometimes it would give us more free text explanation, even when we were trying to control that with through parameters. And so what we notice is that for some of the outputs, it might say, yes, the patient is positive. And so in some cases within the first, sentence, we could get with some high confidence the right answer, but it would take some additional processing. But we realized we didn't want to have to do this kind of post-processing. But we also wanted to give credit where we could. And so we came up with a way of scoring whether or not it followed instructions, like, did you tell us positive or negative, versus giving us a more verbose answer. And so we married that with the overall F1 score. And then that helped us kind of create a composite score for looking at how well it followed instructions, and then gave us what we were expecting. And it was actually right. And so you can see here by doing that, we could focus up on the upper right hand corner, and we can see a few of the models were able to do that more effectively. And so we could make a better decision about which one we wanted to select versus another. Additionally, again, this was earlier. So we were seeing, like many other people, that interesting phenomenon that was coming out from the rationales that we asked the large language models to provide. And so we wanted to do a questionnaire where we could do a qualitative or formative evaluation of how well the LMs conducted the task. And we created a questionnaire to ask questions around criteria of coverage and coherence. And so specifically, we looked at measures of coverage, like asking our chart abstractors, does the rationale accurately represent the information in the original text? And we came up with a scalar, a Likert scale. 5 meaning yes, the rationale covers all important information present in the original text. 4, mostly the rationale covers it, but all of the important information, but not all of the important information, all the way down to 1, where it would say, no, the rationale does not cover any of the important information in the original text. The idea being that we would have them kind of subjectively pick on the scale for each one of those questions whether or not it does or doesn't, or something in between. And we did the same thing for coherence. So is the rationale coherent? Is it easy to read and understand, or is it not? And so what we found was a few things. If you look at the bottom left-hand graph, the distribution, you'll see that, most often it's a 5, like it's, was outputting a rationale that covered all the important points, those 3 points that we had talked about earlier, that had to be true for it to be in-house cardiac arrest, or if it said no, that explained why that there was something missing. And that the rationale was easy to understand and read. But in a few cases, we found that those scores were a bit lower. And so in the cases when we were seeing that they weren't quite at a 5, it was because, 1, in terms of coverage, it omitted key clinical details, such as whether or not the patient had chest compressions or not. Additionally, there could be issues with coherence, meaning that the output may end mid-sentence. So we might see some fragmentation in the way that it was presenting some of the information in the rationale. And I suspect that might be because we had some restrictions on the token length. We were only expecting about a 500 character response, and sometimes that would cut off. So maybe giving a little bit more input about how best to create those rationales would help that. Additionally, we saw some repeated phrasing and contradictory statements where it may assert that a cardiac arrest occurred in the outpatient setting, or conflicting information about what the inpatient status was at the time. Additionally, we asked questions about relevance in hallucination. And so specifically, we saw that in terms of relevance, that sometimes we would get an unexpected result. In a very, very odd case, we got a pseudo prompt that was returned back to us that asked us to please determine whether or not the text is related to computer science, and if so, please return yes, otherwise no. So completely unrelated to what we were doing, which was very surprising and strange. We also saw a phenomenon that one might call hallucinations, specifically where it might be misinterpreting certain types of terms that may occur within the narrative. So for example, it may fabricate some information like it misspells TNK or mislabels TNK as tissue plasmagen activator instead of tenecteplase. But I think that may also be because some of the, I think it's alteplase is a synonym, I think, for TPA. Whereas tenecteplase has, some partial word overlap, which is kind of interesting. Additionally, it may invent some clinical events where we would see chest compressions and cardiac arrest in the emergency department, where it was misinterpreting a reported resuscitation for renal resuscitation as opposed to cardiopulmonary resuscitation. So not really quite understanding maybe how the adjective changes the concept and the relevancy of that concept. We found that some notes were more prone to hallucinations than others. For example, the plan of care tend to have more hallucinations, and we suspect that's because a lot of them are in the future tense and things that could hypothetically happen, but maybe haven't. And so again, this was kind of this earlier work where, again, we were trying to get our feet to understand which LMs to work and what are the pros and cons of each of these. And I think the takeaway here at the time was that we could do a lot of work with composite scoring to be able to make those decisions, as well as varying the different types of LMs that we're looking at. And perhaps also another thought might be looking at some of the parameters and things to developing them to look and see if there's a correlation to better performance, for example. That said, my lab does a lot of phenotyping, and I think rather than going through all the different use cases that we have right now, I'll just illustrate that we have a lot of work that's going to be coming out in the next couple months, specifically through AMIA. You're gonna see some work and more innovative work in auto prompt optimization work done by my PhD student, Mr. Sai Huang, as well as some work in inferring scores from clinical notes for deriving multiple sclerosis progression with Sai and my postdoctoral fellow, June Lim. Additionally, we've been doing some work looking at large language models and trying to phenotype GI disorders like eosinophilic esophagitis. Sorry about that. That's a mouthful. By my former postdoc and now assistant professor at Northwestern, Dr. Corey Ketchum, and more. And so with that, let's go ahead and move over to the bedside, where we're doing a lot of work to drive more clinical informatics. As Dr. Huashu had mentioned, we do a lot of the work in this space and a lot of innovative new works as well. So in addition to my roles here at Penn Medicine and beyond in the informatics space, more recently, we've established something called the Center for Applied Health Informatics, where we really wanted at Penn to design and implement a more integrated health informatics solution and various tools for advancing high priority health system outcomes. And so the idea being that, at Penn, probably like at Yale, you have a village of groups of individuals and centers, a center of centers almost, where everybody can contribute to a piece of the problem. They could provide domain expertise or implementation expertise or methodological design, et cetera. And so at Penn, we have a very similar thing. We have various centers that specialize in areas of, for example, quality improvement and clinical effectiveness, EHR transformation, as well as our Center for Healthcare Innovation on the hospital side. And on the university side, we have more methodologists and groups within our nursing informatics division, within our computer and information science, as well as our Institute for Biomedical Informatics. And so the idea with the center is that we wanted to foster collaboration across these different groups. We wanted to enhance the speed of delivery of those toolings that would be developed. We wanted to reduce unnecessary variation in different tools that might develop to solve the same problem. So having better coordination across the entity. And we more broadly wanted to amplify our presence as an institution within the applied health informatics space, which up until the last few years, we've been known more as a basic science institute. So we wanted to start making movements to build that capacity. If you want to learn more about our center, please use the QR code in the bottom right. So one of the first problems that we were tasked with was looking at patient safety, which is not anywhere near a solved problem. In fact, there's a lot of reports and articles that have come out over the years highlighting different areas of interest and focus for trying to reduce issues with patient safety, starting with the Institute of Medicine's report in 1999 to Error is Human, then moving on to the Crossing the Quality Chasm in 2001, where there were specific dimensions of safety and quality that should be reviewed, particularly safety effectiveness, patient centeredness, efficiency, timeliness, and equity. And more recently, with the New England Journal of Medicine, we see updated studies about adverse events in healthcare and opportunities and challenges to address some of those through patient safety and artificial intelligence through IHA. So we want to kind of continue in this vein, and we wanted to address in our own institution some of the identifying and understanding some of the trends of patient safety issues that may happen throughout the institution. And so what we realized, though, is that it can be kind of difficult to analyze trends and proactively prevent harm to patients, although we do capture a lot of information about that. For example, we collect information through our patient safety reporting systems, RL Datex, for example, and MIDAS, for any potential or actual patient health or safety events. And so the idea, though, with reporting is to be able to identify and analyze trends in order to be proactive about mitigating those and to put in supports. You need to have high quality data to do that. And what we found was in our system, our current state is that safety event reports are self-reported. They tend to, the quality and the quantity of that is really dependent on the staff themselves and their how comfortable they feel about reporting information and the amount of time it takes to place it in. Investigation goes well beyond just the initial reporting. Sometimes that also has to come from further investigation, additional facts being added from the EHR and interviews, for example. The reports take time to enter, and it can be really confusing to decide which category you tag that event as. And not only that, you're forced to choose one. So you can imagine there can be a lot of heterogeneity, particularly if there can be really, in theory, more than one tag that's appropriate. There's a lack of governance and oversight on the use of the data, which was a big need and something we worked out with legal and with our clinical effectiveness and quality improvement group, as well as the fact that this data is actually stored in 2 different systems across our entity, and we need to kind of unify it. So we've been working with our CEQI team to try to develop out the technology needed to be able to ask the question naturally, what reports are related to workplace violence, for example, and to be able to make suggestions at the time of reporting about which tags should be tagged on those events, thereby hopefully removing the need to manipulate the data on the back end yourself and to be able to correctly ascertain more than one label that correctly identifies exactly what's being reported in the narrative. And our goal to this is also to kind of unify these systems into one space. And so to get at this idea of being able to analyze trends, we asked ourselves, well, what are we trying to build and how would we need to build that? And I want to give a big shout out to Dr. Susan Regley, who's our human factors expert here at Penn Medicine, and a tool that she developed called a Mad Lib to be sure that we were developing tools that do exactly what's needed and to figure out what is exactly needed. And so this tool here you see on the upper top part of the screen, her Mad Lib, is where you define 5 key points before you start to develop an informatics solution. First is the role of the person for whom this tool would be serving, the stakeholder, the task context, some information that's important for understanding when this tool would need to intervene, some unknown state, something that you don't know about that you need to know that the tool should be helping you with. What is the intervention? So what is this information it's providing you? And how do you measure that it actually worked? And so with that, we applied her Mad Lib to conceptualize what it is that we wanted to develop. And specifically, we said, as a safety executive, when I am deciding where to implement interventions to reduce safety events, assuming if I, have a budget and I have resources to do that, and I need to know where to adequately place them. If I knew all the events that should be tagged with a particular event category, I could then calculate the size of the problem, the location, the common cause, in order to determine the nature and the location of interventions where I can, targets where I can actually place those interventions to mitigate those or to address them. And so with that, we were able to kind of conceptualize the idea of developing such a system that would help us to not only, again, tag things, but also to tag the right information that would be needed by the executive to be able to make decisions about how to create those interventions. And so this was work, again, led by my NLP PhD student, Mr. Sai Huang, as well as one of our data scientists in the hospital system through Penn DNA, Mr. Mike Becker, where they've worked together to develop a solution for doing automatic tagging of those safety net reports. Here in the middle of the screen here, you can see some of the categories from the system, as well as the interface for being able to report those specific event types and the various types that you can choose from. So the idea is to try to enhance this workflow and to make this better. And so with that, we used large language models, specifically GPT-4o, to define what the task was, again, from the context of a safety leader in the health system that's being tasked to review these narrative reports and to be able to tag them. Additionally, we gave it definitions for specific key patient safety events that were of interest to us. In this case, it was physical violence, and so we have some examples here. We provided some few-shot learning as well as a chain of thought to inform the LM about how best to solve the problem and how to generate not just a dichotomous outcome of, yes, this narrative report is physical violence, or no, it is not, as well as other labels, maybe more in more detail, like verbal abuse and threat of future violence, for example, but also to answer the who, what, when, where, how. So here on the upper right-hand corner, you can see some additional information that we derived from there in our questions, including a description of the incident, whether or not it was physical violence and why, who was the aggressor, who was the victim, what location did this happen, and at what time context. A couple things that we kind of learned about this project was one, we had just started doing few-shot learning. And so we were trying to understand, well, which instances would be the best training instances for the LM, like which instances would give the most information and knowledge. And so we thought, well, we had 3 annotators annotating any individual narrative. And we thought, well, if all 3 annotators agreed, then that would probably be, in our mind, a pretty clear case, right? In comparison to one where maybe only one person had said that it was that label, and it ended up being the label in the end. But maybe because there was some unclarity, that might be a proxy for uncertainty. And so we were looking at things like the number of annotators that had to agree on an instance for it to be considered a more certain or more clear training instance. And we didn't really see any trends in that. We realized from this that perhaps maybe some auto selection of the training instance might be useful for trying to develop better prediction, and maybe deriving fewer of those instances for providing training instances or for providing learning. We also learned that maybe we don't have the right words. So this kind of led us down this idea of doing more automated prompt optimization, where we would let the LM, after we give an initial prompt, generate multiple candidate prompts and mutate the way the prompt is and change the phrasing in order to optimize its performance and being able to do the classification. And so we're doing a lot of that right now. And we're also moving beyond GPT-4o, some of the more latest large language models, including GPT 4.1, O3, as well as some other open models, Llama 4. We're also expanding our annotated data set to include more instances, realizing that we had just a few hundred to get started. Okay. So that was a very, again, that use case was more so in the quality improvement space. More recently, we've been moving into the clinical decision support space. And in particular, I had mentioned earlier that I am a methods core director for our suicide prevention center. And in that, one of the aims is that we want to provide better informatics support to help with clinical documentation that can help improve patient health outcomes. And so this is work being led by my postdoc, Dr. Hyung Donnelly, in which we were looking to automate scoring of safety planning templates in our outpatient settings, specifically within our emergency departments, as a way of ensuring that we have good plans for patients that come in exhibiting low to moderate suicidal ideation, and that we can have good transitions and follow up with them to mitigate suicidal risk. And so this paper just got accepted through JMR Mental Health and will be published here in the upcoming weeks. But for folks that are very new to this space, a safety plan is a plan that is developed with a patient to bring awareness to the patient, to the clinician about the patient's personal warning signs, and pre-plan specific strategies in order to prevent and to manage those behaviors and ideations during an acute suicidal crisis. And that's being done in part because there's been studies within the VA, for example, where we have a more higher risk population in this space. And there's been studies that have demonstrated that using safety planning interventions can reduce suicidal behavior when compared to usual care, but it works whenever they're more complete and the quality of those plans are more, they're more specific in the types of, for example, the warning signs and the coping strategies, for example, and other parts of the plan that are specified. And without that, it's maybe less effective. And so our goal was to assess the feasibility of creating an LLM-powered safety planning intervention rater that could help clinicians know how complete and how, the quality of their completion of these in order to give feedback to say, hey, could you be a little bit more complete here? Or could you finish completing this part of the form? It would be really necessary. And so with that, there's this scoring system you'll see here on the right where we could score the different responses to each of these different steps, the warning signs, internal coping strategies, people in social settings that provide distraction, among other different steps. And we can score those about whether or not we think that, one, there was a response or not. It's 0 if there wasn't. 1 if we thought the response was a bit more general, versus a higher score like 2 or 3, moving to something more somewhat specific or very highly specific. And so let me give you an example. An example of, for example, a coping strategy might be that the patient listens to music. But a more specific response might be the patient listens to the Beatles, a specific artist, for example. And so the idea with this is there's a scoring algorithm for determining how, whether or not they've completed all components and whether or not they've applied, selecting the responses, those that are most specific, and scoring those more higher than those that are less specific. In addition to that, though, one thing that we noticed was in the instructions, we thought, well, that's kind of subjective, whether or not something's really specific or not, even with some detailed examples about whether something is or isn't. So we wanted to maybe look at the precision of the responses and maybe collapse some categories, realizing that, perhaps it's harder to make a distinction between a 2 and a 3. And maybe we should collapse those. And if we do that, and then we rescale, maybe we go to a 3 score ranking. So 0 for no response, 1 for general, and 2 for those that are more specific, versus those that maybe are in the middle. Maybe it's harder to do a somewhat versus a general. Maybe those, then in that case, we would, instead of calling it a high precision system, we would call it a low to moderate precision system. And so using these different scales, we wanted to see, could we get better performance? For our data set, we had over 200 manually graded or rated safety planning templates. But some of these templates had came in where they needed optical character recognition to be able to parse them out of a PDF, for example. Before that, we were able to process those through our large language models. Here on the upper right, you can see an example of how we may have scored these with an example for each of the responses. Oftentimes they were very short and succinct, and we provided some reasoning from the LLM about why it classified it. You can see at the bottom a little more detail about the prompts that we use, particularly describing the different details within this each of the different recorded scores and some of the outcomes, the outputs that came from the different language models that we tested, specifically GPT-4, Llama 3, and O3 Mini. We chose these because we have often used GPT-4o as being kind of our LM to beat, so to speak, as new LMs have been coming out. But we also wanted to keep an open weight LM to see, particularly Llama 3, because we were finding that it was doing pretty well on most tasks, as well as some of the newer ones that had better inferencing capabilities, like O3 Mini, where we thought, given the subjectivity of this task, maybe it might do a little bit better. In this case, for GPT-4 and Llama 3, we use different temperature settings like 0.1 up to 0.9. And O3 Mini, we compared different reasoning levels, including low, medium, and high. In terms of the corpus itself, we realized it varied a bit. In some steps, like warning signs and reasons for living, it tended that the data set skewed with more specific or somewhat specific responses. In contrast, the internal coping strategies and making the environment safe tended to be a little bit more skewed in terms of low to moderate specification of those responses. And so we also found, in terms of how well that influenced performance, we saw that comparing the different models in different steps, we found a few things. One, again, the warning signs and reasons for living tended to skew more to the more specific categories. And in here in red, you see they also tended to do better than using the original or the low to moderate scales. And conversely, that pattern also held with the low to moderate precision scales, where specifically for making the environment safe and internal coping strategies, we found that the LMs tended to do better on those. And again, we think it's more of the fact that that tends to be most of our data set. Additionally, here's a breakdown of some of the performance in terms of recall and precision with the best performing LM in each of those different categories. And in the case of that on the upper, I guess the bias here, we find for those that have that performed better for the high precision scoring, Llama 3 did best for the warning signs. But if you looked across all the remaining three, including reasons for living, as well as the internal coping strategies and making environment safe, we found that O3 Mini actually did the best. And in those cases, we think perhaps in these cases, more reasoning is important for being able to correctly classify those cases. Next, we're going to go to the ambient space. This is some work that I did with my K-Mentee at the University of Pittsburgh, Dr. Andrew King. And I want to make the disclaimer, this is before DEX Copilot and more generative AI approaches had came about. This was work that we did as part of his case submission and as part of some internal funding for him as more of a proof of concept. So we're going back to the future here. And if you want to learn more about some of this work from Dr. King, you can see it in the Journal of Biomedical Informatics. But the idea here was that we wanted to develop a voice-based digital assistant for intelligent prompting of evidence-based practices during ICU rounds. And so specifically moving from a multidisciplinary rounding team in the ICU to be able to take this data, to record it using some microphones, to convert it using automatic speech recognition, NLP, and to be able to overlay a set of rules to be able to present an evidence-based checklist that would be automatically completed during those rounds. And so what did that mean? The checklist itself is the ABCDF bundle. This specifically has 6 components to it, including A, standing for assess, prevent, and manage pain. B, both spontaneous breathing awakening trials as well as breathing trials. C, choice of analgesia and sedation. D, for delirium, determining whether or not the patient was assessed prevention or management of delirium in their case. assessments of early mobility and exercise, as well as whether or not the family was engaged or consulted about their care. And why these things? Well, they're commonly assessed in the ICUs each morning, but they're done so on a checklist that is static, oftentimes in paper. And while there had been some proof to show that these paper checklists can improve patient outcomes in the long run. Specifically, a clinical trial demonstrated that with human prompting through a nurse, they were able to associate lower mortality in the ICUs using these checklists as, for example, reminders to collect this information in next steps for delivering care. So the question became, well, that's a lot to go through. Could this be done as a digital assistant? And so the idea being, if we have a static bundled checklist, someone has to go through those manually and look at each of those questions. But if during the conversation there are some things that don't make sense because, for example, the patient's not receiving a breathing tube, then why would you ask that question? Why would you need to review that? So could we remove extraneous questions on the checklist that don't need to necessarily be addressed or maybe not relevant anymore? And could that reduce the amount of items that need to be reviewed? Or could we really identify those that do in preparation to think about the next steps, which might be electronic ordering it within the EHR to electronically data capture that information as well as facilitate those orders. And so Andy completed this work at 2 of the ICUs at a large teaching hospital between August and December of 2021. So this is in the midst of the pandemic. He did a fantastic job in the ICUs, particularly when they were being used. And he collected data for the ABCDF bundle through a critical care nurse and collected the audio within that space using a microphone. There was 106 patients that were discussed over the course of a little more than 2 weeks. And many of the people in this population were a bit older, with a median age of 60. Most were male, and many of them were receiving invasive mechanical ventilation. Now, in terms of the informatics solution, we have these transcripts, and that next we had to put together a pipeline to be able to transform this information into a checklist that you saw earlier, a more dynamic checklist. So specifically, at the time we were using speech to text via Amazon Transcribe to convert those transcribed audio files into flat text files. And then we had annotated aspects of the ABCDF bundle for those 6 different classes you saw earlier in terms of whether or not action was needed or not for each of those. And using a bioclinical BERT with a multinomial logistic regression, we were asking it to predict those different classes of action. So for example, information whether or not in this case, maybe a statement would be whether a spontaneous breathing trial was actually discussed or not. And then using a rule engine, we created some inferencing to be able to create the checklist that would need to be reviewed. So specifically, if a patient is receiving invasive mechanical ventilation and not in the spontaneous breathing trial was not discussed, then create a personalized set of prompts by adding SBT. And with that, we were able to demonstrate through this very prototypic pipeline that the system could generate 56% less prompts per patient with 50%, give or take 17% greater precision. And so again, the idea here was as a proof of concept, and clearly now we're more in this kind of generative space. So we're seeing better, we're seeing an opportunity to modernize this with more generative AI and larger language models. But the idea here was, could we demonstrate that there can be some benefit to use this? And we think there is. Okay, I know we're getting close to the end, so I'll speed up just a little bit. And we'll end here in Beyond. So moving beyond the traditional walls of a hospital, we've been working a lot in this automated chatbot space. And specifically, this was work done with my former postdoctoral fellow, now an assistant professor at The Ohio State University, Dr. Natalie Lee, as well as with our data scientist, Tai-Ben Luong, where we developed a chatbot clinical model for managing patients' hypertension at home, and developed an automated pipeline using NLP to be able to take information, for example, from the patient, you can see in the figure here, to be able to accept messages through a platform we call Way to Health about the patient's reported blood pressures, whether they were taking medications, whether they had some kind of a, event. And the idea was the NLU system and the rule engine would review this and triage it to the right people. So it would go, if it was a medical question, it could go to the physician. If it was need for a medication refill, it would go to the pharmacist. If the patient needed an appointment request, it would go to the scheduler. And for things that seemed like normal text messages that would come from the patient, then that should be answered through frequently asked questions or assessment of normal values, and just an outbound automated message should be able to handle that, right? Encouraging them to continue to monitor themselves and to confirm that we got the message. And so this through this work, this is where we began working more in a deployed space. So really working from, instead of just a prototype or a basic concept, now we're going to move towards developing a tool and operationalizing it. And doing that meant that we needed to return back to practices in safe deployment. Specifically, in this case, we used a human in the loop. And the way that worked was we started with an actual human acting like the chatbot to answer questions and to get a sense of the types of needs by the patient themselves. And then as we started to create a classifier to tag this information according to the semantic type and the intent and the actions associated with it, then we could start moving the bot to taking this information, and we can hold the action so it could be reviewed by the human before sending it back out. And so in this way, we could ensure that is the bot acting as we would expect? Are we getting anything that wasn't seen in the training data? And we can, over time, we can reduce the effort on the human and increase the effort on the bot. And so we implemented this framework, and in doing so, we implemented a trained model for tagging a patient's message as being blood pressure related or whether or not they had a medication need or not. And we trained a very simple conditional random field with over 300 patient messages that were annotated by our project assistants with a very high reliability. And we used simple features, in this case, message length, word choice, verb tense, punctuation, among other features. And we asked it to, again, classify whether or not the message was blood pressure related, as understanding that they were reporting their blood pressures daily, and whether or not the message needed to be reviewed more broadly by somebody that was on the care team, or it could have been automatically answered. And so what you see here is on the leftmost side is our machine prediction, and on the top here we have our human review. And you can see down the bias that we had pretty good performance, and most blood pressure and messages were correctly triaged. In a few rare cases, we had some disconcordance. And this is of the over 1,300 messages submitted by 171 patients. Specifically, we found that very few messages were flagged but maybe didn't need review, which is a good thing. We want to be able to flag messages, at least a few messages, to make sure better safe than sorry. We don't want to miss anything that would be critical. In a rare case, a message could be missed by the NLP system. And so in that case, in this case, it wasn't clear what it was. I believe we thought it came in as like a image, and it wasn't caught by the system because it was not a system that was trained for images, was trained for text. Additionally, we did an overall extrinsic evaluation or summative evaluation of the tool. We, in addition to its formative function to make sure it was working, we also want to make sure that participants enjoyed using it. And so we did a survey of over 117 participants in the spring program using net promoter scores to determine how likely they would recommend the program and the reason for that. And we found that we had a pretty good report rate, about 40%, and really extremely high patient satisfaction numbers at 93 for net promoter score, and meaning that we felt that this is something people are going to use and they're likely to recommend to other people. And then it's also worth noting that there was no mention of these auto responses, potentially suggesting that they did not contribute really significantly to overall experience. One thing to note is the NLP piece was just one piece, and that there's quite a lot that has to go into operationalizing NLP. And so I want to acknowledge the fact that this was done by a very large team. We had a clinical champion that helped us define the direction and understand the workflows and the success outcomes that we wanted to optimize. We had a clinical team that provided end user feedback to inform how we developed the tool and the dashboards and the interfaces. We had an operational assistant that helped us develop the back end. Providing support as well as engagement by our privacy officer, who we had, again worked on the safety net project, which she worked with us here to ensure that we had adequate measures for ensuring safety and good flow and capturing potential misses. Our NLP and NLU experts for developing out the system, as well as our user interface and user developer team who helped us define what those human computer actions should look like. In addition to that NLP system, we also had patient-facing messaging applications for them through the Way to Health tool, although you could use other tools like Twilio or other patient portals if you wanted to operationalize what we were doing. For the NLU model, we used Raza, but you could use other tools like Lewis or in this case, maybe even generative models like GPT-4o, for example, and we're doing some experiments now to see how well if we can improve on what we were doing through our supervised learner, as well as dashboards for integrating the outputs from this information. For example, reporting of blood pressures should also go back into the electronic health record so that the clinicians always have a good understanding of the broader clinical status of the patient outside the traditional EHR. And of course, Metabase for being able to monitor engagement. That said, this work happened because we have a very diverse and growing lab where we have our strength is our diversity. So we have folks in informatics, but we also get a lot of people from linguistics and engineering and arts and sciences, as well as not just more computationally interested students, but also those on the clinical side, a lot of different clinical fellows who give us very interesting use cases to solve. And I want to also acknowledge that we got a lot of funding from the National Institutes of Health, as well as other foundations, and are really grateful for that continued support. So that, I'm going to go ahead and pause and take any questions that you may have. Thank you so much for the opportunity to present today. Yeah.
Thank you, Dr. Mowery. That was really some interesting lines of research. Dr. Shu had to leave at 4:30, so apologies for that. And in interest of time, maybe one or two questions. Yeah, Kevin. You want to come here? No, nothing was there. Yeah.
We want to read the chat questions first.
No, there's nothing. You can go ahead.
Oh, there's nothing. Okay. Hey, Dr. Mowery, can you hear me?
I think I can hear you. Yeah.
Cool. Okay. So, excellent talk. I really learned a lot, and I think there's a lot of intersection in a paper that I'm working on and your assessment of language model, especially the reasoning capabilities and the chain of thought processes that you showed. I was wondering, maybe you mentioned it, but I might have missed it. How many people were involved? How many clinicians or experts were involved in that qualitative assessment that with all the rubrics, and how did you develop the rubrics, right? Like,
Yeah.
'cause that's something that I'm trying to figure out right now.
Yeah, I think you're referring to the questions that we had in terms of looking at the quality assurance on
Yeah.
the LMs. Yeah, good question. So I would say initially we had done I collaborated with Abid Sarkar at Emory University, specifically looking at things like hallucinations and coherence for I think there were substances from descriptions and discussions and maybe Twitter or Reddit. And so we were starting from that initial work with him and building on that in terms of the types of questions we wanted to ask and how we wanted to ask them. And we had 4 clinicians who helped us define the questions and how we
Okay.
specified them, and 3 of which did the annotations themselves.
Okay. Okay.
Yeah.
And remind me how many pieces of data did you guys annotate again?
Good question. The paper itself is available. This paper evaluating large language models. You can find it on medRxiv.
Okay. Cool. All right. Thank you. Yeah, and Abid Sarkar, very famous. It must have been crazy to work with him.
He's amazing. He really
Yeah.
is. I'm hoping we'll get to work again on this work. We had just resubmitted a grant that got a pretty good score, but
Nice.
hoping we can dive a little bit more into this. And I think at the time he was very interested in social media data, which he is an all-star in, but we also wanted to do some work on large language models in this area of substance use, but also within clinical notes, which is where I sit in. So really
Cool.
looking forward to be able to expand some of that LM work in both of those. Yeah.
Cool. Thank you, Dr. Mowery. Excellent work.
Thank you. And
I'll just conclude with one question, I think. What really was interesting to me was about that ambient systems. Do you really have plans to go the new way with the agentic framework on that?
Yeah, actually, so this is work that was done by one of my K-mentees at the University of Pittsburgh and Dr. Andrew King, and very excited about that. In fact, we're going to be building on this work. Initially, it was bioclinical bird, but we're going to be moving into generative AI to do some of the classification, to be able to assess not just the completion of these types of checklists, but also thinking about how do students and trainees think through cases, because it becomes a very natural data set where we can better understand how they reason and how to better get them to diagnosing and therapeutic decisions. And so I'm really excited that I'm gonna start working back with Dr. King here in the fall, and we're gonna start testing some of the more the latest and greatest generative AI models and automating that, as well as facilitating recommendations to trainees to help them manage patient cases, in this case in an ICU setting. Yep.
Thank you so much. Looking forward to more from your lab. And thank you for taking the time and presenting your line of research.